do them day in, day out. So our point, from the point the assistant port goes in to the robot docking, we've got down to under 5 minutes. So we're generally able to do it within about, usually between about 3.5 to 5 minutes, the robot's docked. But that's down to, that's a big help from the scrub staff and from the, they're very fast. So the 3 robot theatres we have, all the staff do. So if they're not doing HB robotic cases, they'll be doing urology robot cases, or they'll be doing gynae robot cases. So they all know the instruments very well, the setup very well. So it is actually very easy for them to help us.
If you have to say for someone that is starting robotic hepatic surgery, which level 3 is more difficult, right or left?
Right.
Right. Okay.
Yep.
Thank you so much.
Guido, digestive surgeon here in Recife. Thank you very much for your lecture, Ricky. Really very good lecture. And I would like to ask, I've seen one of the major complications surgeons fear in hepatectomies are postoperative liver failures. And this can be catastrophic in some instances. And normally we rely on volume liver tests. But there is a knowledge that volume not always corresponds to function. And I have asked on an event some weeks ago, a friend of Cesar's, Fabiano Perdigão, which is in Salpêtrière, because of on the robotic platform, it will be easier for you to perform the test. And allegedly, on his paper, he states that the intraoperative liver function test with indocyanine green is superior to preoperative liver volume tests, like volumetry and all. And I would ask if you have any experience, or are you aware of any experience in the UK with intraoperative liver function tests?
So in terms of intraoperatively, we don't use indocyanine green. All the patients that we tend to put through to liver surgery, including the robotic, they would all have, we always get a liver specific MRI before surgery. So we use that as our standard for guiding surgery, but I have no experience with using indocyanine green during, I've used it a couple of times during cholecystectomy just to see what the docs look like, but in terms of using it for liver resection and guiding liver, I've got no experience of that.
But do you think it's something going to happen?
I can see. I mean, there are people just down the road from us in University College London who are looking at the ability to use the robot to allow the sort of the stiffness of the liver to be assessed intraoperatively, using indocyanine green and using other dyes. That's very much in the experimental phase at the moment. I'm sure it will come through because of the amount. I mean, I think we'll probably get asked to trial these things maybe in a year or so's time. I think it will come. I'm not sure how useful it's going to be until we've used it. So I'll probably be relatively guarded about making any statements about how good they are or aren't at the moment. I mean, certainly I wouldn't have the experience to be able to come down one side of the argument or the other at the moment.
Okay, thank you very much indeed.
Thank you.
Thank you.
Thank you, Ricky, and thank you for having Crispin there also with you. That was a fellow with me in the Kings. Train him well. Hopefully he's not giving you lots of trouble. And thank you.
Oh, no, not at all.
Thank you for being with us. We will have a next lecture also. If you want to see, you're invited. If you have things to do, of course, you're open to go. If Crispin wants also to see, thank you guys for your participation.
Thank you.
So
Thank you.
Thank you very much. So the next talk will be about the treatment of PE in pancreatic cancer and chemotherapy and surgery. Professor Keith Roberts is consultant HPB surgeon and pancreas lead from Birmingham. He's testing now the slides to see if everything is okay. We also have other colleagues here from Birmingham that will give you a hi after Professor Keith, okay? Are you hearing us?
Hi, everyone.
Yes, thank you.
I can hear you great. You can? Great.
Thank you very much.
So, well, thank you. Thank you very much for the kind invitation to speak, and it's great to see and hear Ben's voice, and thank you very much the organisers for the invitation. So my name is Keith. I'm a liver and pancreas surgeon from Birmingham. I'm the pancreas surgery lead for the Royal College of Surgeons of England. I'm going to give a bit of a provocative talk, and it's prescribing PERT in pancreas cancer. It's as effective as chemotherapy or surgery as treating pancreas cancer and survival. So, how can this be? Well, let's have a little think about, first of all, how many people with pancreas cancer get PERT. So if we look at data, there's only 2 population-level studies that I'm aware of worldwide, and they both show very similar PERT prescribing rates, and over similar periods. So this paper by a US group and a paper by our group, and you see 22% of patients across those countries with pancreas cancer received PERT, with a gradual increase in PERT prescribing over time. We performed a prospective national audit in 2018, and this came after national guideline in the UK saying every patient with pancreas cancer should receive PERT. 84 hospitals, nearly 1,500 patients. If you were unresectable, then less than half the patients received PERT. If you were resectable, 3/4 of patients received PERT. And it depended in the operation pathway, your chance of having PERT. If you were waiting for surgery or if you were on neoadjuvant chemotherapy, around about half the patients received PERT. If you had a Whipple or a resection, that got close to 97%. If we plumb in our most recent data then, in the UK, we've got to around about half of all patients receiving enzyme therapy. But remember, the national guideline says all patients. So why does the national guideline say that? Why is it so strong? Well, when we did our national audit, we also did an analysis of survival benefit. And even at just a 3-month snapshot, we saw a significant difference in survival as short as 3 months. So how can this be? Well, first of all, I think pancreas exocrine insufficiency is a bit of a soft name for what it is. It is pancreas failure. It is organ failure. And I think we have a fundamental problem that pancreas exocrine insufficiency does not convey the importance of the problem. We know that organ failure is bad for you. You don't need me to really tell you, but I'm going to tell you, I'm going to show you. So liver failure, heart failure, lung failure, kidney failure, even brain failure. The worse a person's organ function is, the shorter their survival is. We know with diabetes that as soon as insulin was discovered and insulin became a treatment for diabetes, that mortality dramatically improved. And you wouldn't dream of having a patient who is diabetic and not treat them. But what about pancreas exocrine failure? What about exocrine insufficiency? So what is the natural history of untreated exocrine failure? Well, the problem with pancreas cancer patients is they have cancer. And so obviously survival is dominated by the disease. But if we look at patients with cystic fibrosis, because as you know, they have pretty much a developmental pancreas exocrine insufficiency as they go into adulthood. And this is a great study. You don't always need a randomized trial. Sometimes you just need a good observational cohort study. And 2 famous centers for treating cystic fibrosis across the world, one in Toronto, one in Boston, they got together and they realized the patients in Toronto were living longer. And the Toronto patients were living 9 years longer than the Boston patients. We're going back now to the 70s and the 80s. And they got together and they looked at their processes. They had good physiotherapy for the chest, they had good antibiotics, but in Toronto they were giving enzyme replacement therapy as standard and a normal diet, and in Boston, no enzyme therapy and a low-fat diet. The conclusion of this paper was that this was untreated exocrine insufficiency or treatment with enzyme therapy. So what about in pancreas cancer? Well, this study looked at patients purely stratified by their fecal elastase at presentation. and patients with a lower fecal elastase had a worse survival. This study from one hospital in north of Spain took patients with unresectable pancreas cancer treated by two different hospital teams. One team was giving enzyme therapy to all the patients, one team gave no enzyme therapy, and a big difference in survival. The patients who received enzyme therapy, though, were also more likely to get chemotherapy, so there's a little bit of confounding here. If you pool the available data in unresectable cancer, because there's now several papers, there is a survival benefit with enzymes. And I want to draw your attention to the magnitude of benefit. Untreated, 8.7 months. Treated, 12.6 months. So patients with enzymes live about 4 months longer than those without. And 4 months in unresectable cancer is similar to chemotherapy. I think you'll agree with me there. Well, what about surgery? Well, this is a nice paper. So this looks at exocrine function before and after a Whipple procedure in Japan. And what the Japanese group saw is obviously after a Whipple, the proportion of patients with exocrine failure increased from 46 to 75%. But at long-term follow-up, only a third of patients had exocrine failure. Well, how can this be? Because we know the pancreas doesn't recover function after surgery. But perhaps this is survivorship bias. Perhaps the only people, or perhaps the people with normal exocrine function were actually those who could survive in the long term. Okay, I appreciate my evidence is a bit tenuous, so let's make it a bit stronger. This is data from Birmingham. 469 consecutive patients undergoing a Whipple for cancer. And if you just look at the crude analysis without any risk adjustment, the patients who received enzyme therapy lived 6 months longer than those who did not. When you put this into a multivariable model or a propensity matched model, the significance actually became stronger. And what we saw, we don't have fecal elastase in all our patients, but we have duct width, and we know that duct width correlates quite nicely with exocrine function. The bigger the duct width, the worse the exocrine function. And look at the difference in survival in patients who had the dilated pancreas duct enzyme therapy than those patients who received enzyme therapy. And we also saw a trend towards the dose effect, but it was not significant. But with increasing dose, you can see the survival curve moving to the right. Importantly, the dose there is the total daily dose. So over 60,000 units, well, now we give over 60,000 units with a single meal. Most of our patients are now on 200.
Conectar e reconectar de novo. Keith, do you hear us? I think the internet is failing a bit. Talvez de novo tentar eu.
Benefit, that's not a surprise. But look at the magnitude of benefit of the enzyme therapy. It's the same as chemotherapy or surgery. So why is exocrine insufficiency harmful? Well, the physiology is pretty simple, isn't it? The pancreas cancer induces fibrosis, it blocks the duct, you have less enzymes, you have less bicarbonate, and then you have unopposed gastric acid, so the small bowel content is acidic, so the enzymes, even if they're there, they don't work. And a Whipple is a really bad thing to do for the pancreas physiology. You lose the stimulation to the pancreas, and you take away the enterokinase. So really, these patients are absolutely predisposed to have pancreas exocrine insufficiency. Also, with age, there's a natural decrease in fecal elastase, even without pancreas disease or without surgery. We know that malnutrition in cancer is a really hot topic. But malnutrition is fundamentally linked to pancreas cancer through exocrine insufficiency, as well as the other mechanisms of malnutrition in cancer. We also know that exocrine insufficiency is progressive. This study here showed a 10% drop in fecal elastase month on month. After a Whipple, exocrine insufficiency approaches 100%. So why is enzyme replacement therapy beneficial? Well, you don't need a